6 months back and diagnosed as a double disease and underwent PTCS stent to LCX that time. And there was LED CTO.
At a
And now-
different hospital. At a different hospital.
Sir.
A different hospital.
At a different hospital 6 months back. And now I plan for LED CTO. IGS CTO score was 2 with the long segment more than 2 centimeters with calcium and with good LE function.
Yes, this patient is morbid obesity, more than 100 kgs weight. And that's the main one of the issues for access problems, where we had an access of 7 French in both sides. We prefer. We kept initially 5 French on the left side, we'll upgrade. But this problem is he has been stented in the circumflex in acute coronary syndrome in a different hospital. But that time the LED CTO in the mid segment, in different views, you are not able to profile properly where is the exactly now with the dual injection, which is key for success. And the dual injection is key for success. We have done a donor injection for the right coronary with a Judkins catheter and EVU catheter giving the culprit vessel. If you can see that circus stent is patent done outside and the proximal LED had a fibrotic lesion, then series disease in the middle LED. After that, 22 millimeters short length CTO is there. Maybe there is, but distal LED is not filling by the retrograde injection. That's only a negative point that diseased LED I'm expecting in this young gentleman with hyperlipidemia and morbid obesity. Anyway, in this, the strategy is antegrade mainly because the retrograde collaterals are hardly seen and there are no good exit and entry points. Always, this is the assessment in a dual injection because it's a course. Fellows attending, I again emphasize that the dual injection gives the length of the lesion, the dual injection gives about the tortuosity, the dual injection gives of the collaterals and distal vessel size and calcium. These are the points we have to assess in the dual injection. Then the strategy should be done. That's why here always I take a microcatheter support in these cases, but the initial wire should be a very flexible wire where you can track to the proximal cap. If you use a CTO wire, dedicated wire to the proximal cap, you may lose the tip. The secret of success of the CTO wires is the tip. So you should not lose the tip character. That's why use another wire, go to the, that's what I'm doing. I took a 135 Carvel along with a cyan blue wire and I will negotiate this to the LED. As in cranial view, it's easy to track it. I am taking it to the, so now this is the first step I have done. And the next step is tracking the microcatheter to the tip. Now I took the microcatheter to the proximal cap. Yes, there are, after removing this, always see that the backflow is there in the microcatheter. Use a lever lock syringe. I'm using a lever lock syringe here, 2 cc, and nicely lock it and aspirate. See that the blood comes backflow. This is very key because if you never inject into the microcatheter without backflow, this is a very important step. And then I will change to a workhorse wire because I find a short segment. Maybe I can find a neo channel in this. I'm using a Fielder XT, which is my favorite wire. There are 3 wires, Fever XT, Fever XT-R, and Fever XT-A. Most of all these wires have the same strength. Only thing is if a block is little more stiff and to penetrate, I use a Field XT-A and a Field XT-R, even a calcific lesions and a very atraumatic wire, Field XT-R, which can be also used in a retrograde procedure for surfing. So I'm using here the Fielder XT, which because I will see in the antegrade injection only this much came. This is in the antegrade injection, done it again. So yes, this is in the retrograde injection, antegrade. This is filling by some bridging collaterals, filling by the bridging collaterals. So I'll use both antegrade and retrograde wires, and you can take contrast in this. When I am crossing, I'm cautious. The first attempt, remember, the first wire cross, if you can successful, usually CTO PCA is successful. That's very important. Now I went to the, so take the always the microcatheter to the tip of the wire. That is important for support because that centralizes your wire for penetrating the cap. This is the secret. Sometimes we have to shape the wire also or pull back the microcatheter little bit and shape the wire. Now I redirected the wire when it went into the branch by pulling back the microcatheter back. Give one injection, retrograde only. You can give a good injection, take good contrast, give good injection. I use less CNIs because radiation is always, give it. So we got a small septal there. There is some little hot plug there, some knuckle formed, but now I can push the microcatheter. For the good backup, I am pushing the microcatheter here. Always aspirate donor artery. I think it looks like in the track, but for learners, I will tell always seen oblique view. So I take a caudal view also in this case. See, okay, fine. Now we see this is the secret. You call it as a 2D wiring. I call it a 2D wiring. Mathematics 3D wiring is different. Ideally, you can say this can be a 2D wiring. You magnify and show. We have to see whether we are in the right block. Huh? Please bring it to the middle and freeze it. Freeze it, the distal cap and the wire. Freeze it. Is it branch, some branch? Just 1 minute. Okay. You again give a good injection. Okay. Now it is in the branch. Okay. It is in the septal. You can give here. Uh, you see, that's why I crossed it when he is doing the cine, I crossed it. Now I am confident. I entered. You can show the cine again. It's okay. Okay. Parle. Now we are in the correct track. I will try to this two techniques now. If you can track the corbel down, you can exchange the wire. Okay. If there is no calcium plaque, balloon trap. I will remove the carbon. There's now you got some balloons trap it is there, which can be used in a 6 French compatible catheters. Now my balloon is trapped the okay. Now I can easily remove the show the guiding please for the learners. Like I am removing this Carvel catheter easily with a little opening of the Y connector. You can easily safely take out the Carvel, the micro catheter. This is the safest technique of all, deflate the balloon. Now I will take a lowest profile balloon of your choice, which you are working. In this, I think we can try a this alveo, how much size? 2 alveo. Yes. We are trying a 2 alveo. If it doesn't go, we'll go for a low profile thing. This alveo balloon is from the Spectronics and used in many CTO these things. The balloon, this thing is nominal is 10 atmospheres. It is available in 0.75, 1, 1.25, 1.5, and 2. And the burst pressure is around 20. So that is the advantage of this alveo, one of the CTO balloons. Can tell anything about the alveo balloon? You got a mic here? It might be a little. That mic, you can give, he can talk about the characters of the alveo balloon. If you show, he will, I will tell. So ask him to keep the other mic here to Dr. Sudhakar so that he will tell about the characters of the alveo balloon. ಇದೇನ balloon? Now we are dilating the CTO segment with a 2 millimeter alveolar balloon. Dilate. Then is 12, 14, 16. Fine. We have dilated this balloon to up to 16 atmospheres. It could cross the lesion. Do it. 14, 16. Sometimes we do balloon at nominal pressures in the down in the distal CTO vessel for remodeling. These vessels grow in size and flow will improve. Then Even now also 2 grade, no? Because of the, if you see I hardly used any sinis and fluoros I'm doing, even then it touches 2 grade. This is the problem when patient is obese and you have to be careful with your machines. You have to be. That's why we are now going for new machines which have less radiation. Can We have kept a rat pad here, which is supposed to absorb good scattered radiation, and we'll dilate the proximal plaque, show the proximal plaque where is. In the case. I think that is enough. Ah. Change. Very hard plaque.
10, 12, 12,
14,
14.
16. We'll take a ఇక్కడ huh? 12, 14.
12, 14.
See.
Regarding this alveo HP balloon, it is one of the low profile silver balloon like Rayuri balloon. It has a good crossing profile. The tip of the alveo HP balloon will be like our work half wire of 0.156 like that. Our routine upper point tip wire is 0.014.
Now I will do a IVUS on this because I'm not going to give injections. We'll extend the wire with this Carvel again.
Crossing profile is 0.018 and
Always keep your CTO as long as they do their work. Remove them at the earliest. The reason is distal perforations you can avoid these wires. So device tracking also not good on these wires. That's why we go to the routine workhorse wires. How to replace this? Again, put the trapping balloon already is there. And so we inflate the balloon to 14 atmospheres again and thread the Carvel. This is the way we do a wire exchange in CTOs. It's a more simpler way and a very perfect way not to lose the wire axis into the distal lesion. And that's why safe technique. The sister will watch the wire and has come from the Carvel or not. She will hold the wire. So she is holding the wire. Now, once it comes to the tip of the inflated balloon, then we'll deflate the balloon. Now, you have seen we deflated the balloon. Now the Carvel, I will track with my left hand, holding the wire in the right hand. Now we can see that Carvel is going to the distal one. I went for distal and removing this removing this CTO wire. Now I'll put again while putting, I will do a backflow. I will check again. That means it is in the true lumen and backflow is very important. Maybe you can give 2 more heparin. His body weight is very heavy.
ఒక్కసారి ఏసీటీ
2
So-
ఇచ్చేసేయండి. Sir, 2 ఇచ్చే,
Ichese-
2.5 ఇచ్చేయండి.
Okay.
Please, sir. 2.5 heparin more.
ఏంటి ఏది ఏది చెప్పారండి ఇదా ఇవ్వండి
So this is the wire, which is, this is cyan blue wire. So now I am taking the carvel out with the same balloon trap. I'm pulling the carvel out. Now we'll do a IVUS on this vessel. So stenting in CTO PCI is better use imaging because there will be a lot of reporting
చెప్పారని ఇది
on these vessels.
ఎక్కడుంది చెప్పారు
And there will be distal disease, there
Second
is
thing,
spasm, there's
second
myocardial bridges, there's a calcium, and further devices to be used to dilate.
2005
All these things are there. That's why I use
ఇచ్చేస్తానులే, ఇచ్చేస్తాను
IVUS in this. We are using here the Boston Scientific 60 megahertz. Mr. Ravi, who is expert in the IVUS interpretation, technically helps us in most of the cases. You can watch the steps. Somebody can focus the camera, how the IVUS
మా 25
is arranged.
రాసుకో 25 రాసుకో తీస్తాను
You don't show the picture. ఒక ఏసీటీ చెక్ చేయమని ఇచ్చాము. ఇచ్చాము. Yes, వాటర్ వాటర్ తాగడం అలవాటు. Need some water. పర్లేదు, they will get it. Shaji, this will be over another 1 hour meantime, because I was we are doing. Maybe we'll do some Wolverine balloon for the proximal, then see how much stenting, how much drug-eluting balloon. నెక్స్ట్ కేసు ఎవరు వస్తారు, నెక్స్ట్ కేసు ఎవరు రీడ్ చేస్తారు, మీరు ఏమైనా ప్రాంప్ట్ గా రీడ్ చేయాలి. బికాజ్ అన్న హడావుడి ప్రిపరేషన్, ఆయన అన్ప్రిపేర్డ్ ఉన్నాడు. కరెక్ట్, బట్ పర్ఫెక్షన్ ఉండాలా.
ఓకే ఇది రాని ఓకే కదా ఓకే
The Boston, this is opticross, no? So I find the resolution is very good. Only thing is the tip to transducer distance is little more, 20. For a CTO operator, when you put in the side branch, we are taking care of looking at the proximal puncture ambiguous cap. The distance is too long. But if the side branch is too long, yes, it is useful for proximal
Chuddam,
cap
can we
puncture
come back?
also.
Okay, na?
But the image quality is excellent. You can see just like OCT, all the three layers, and you can see intima, subintima, wire positions, everything can be seen. That's why we prefer this IVS.
Question.
There is two things. One is a automatic pullback and second is a manual. It's a simple monorail system, very short distance monorail that you should remember. Until your stiff portion comes, you have to be careful threading the this IVS catheters because you have to be in alignment with the Y connector, push it in line. That's very important until you get the stiff portion. Otherwise, kink can happen in the catheter. So my proximal marker, distal marker has crossed the middle marker, and then there's. So I want a vessel distal portion also very important that I want to go as distal as possible. Maybe that's enough, I think.
Okay.
Yes. The auto pullback started. Little loud. Vessel looks like 2 millimeter in the distal. For a better quality, she's injecting little saline flush into the. Yes, distally, if you see the bookmarking in the middle portion, actually it is in the middle eddy, there is a calcium where exactly at the C2O site. And there is a calcium of almost, I can say 360 degrees calcium in the proximal portion of the mid portion of the LED. Again, there is a very dense calcific lesion what I expected at the proximal LED thing. But wire is in the true lumen. We are in the LM appears clean. Iota. Correct. Now the thing is the distal size beyond the CTO is 2, and at the site of CTO, what is the size and proximally how much? While guide hold. I'm pulling back, na guide hold.
Yes. Vessel?
Distal? What is it?
No, vessel. Distal diameter.
You tell the distal dimension at the mid portion CTO and proximal. There's a calcium at the CTO segment there. Okay. We give some NTG in these things before doing the IVAS sometimes to get the correct sizing. Give some NTG system. Then I will take a shot and see. What is the proximal thing? Does it need any debulking? Anything like a cutting balloon or angiosperm? Scoring balloon? Because preparation, bed preparation is important in this.
Hmm. Mixed redundancy.
So if your I was study proximal vessel size, how much? More than 3. So I will కొంచెం కిందకి middle. So I will do a injection and see. I think this portion of the digital LED is deceased. We are not going to only the segment where that needs stenting of the middle and distal in between that segment we need to dilate further, and the proximal one we may need some scoring, some block modification. You take what is the size of the proximal thing? 3, yeah. We can take a 2.5 so this thing Wolverine there. You want a 3 sizes the Wolverine.
No. Approximately.
3 will take 3. 3 you can take. Always give a caudal view also so that you are not close to the left main. Are you caudal, please? Shall we dilate with the 2 millimeter distally to get a better flow? Uh-huh. No. I am telling you of the distal flow. Dissection. ఎక్కడ అది బెలూన్ ఇంజెస్ట్ కదా, అదేం కాదు, అది కాదు నేను చూసేది. డిజిటల్ వెసల్ ఒపేసిఫై అయిందా అని నేను చూస్తున్నాను స్టెంట్ పెట్టడానికి. We can take a 2.5 and do for both. 2.5 take. కాదు డిజిటల్ వెసల్ ప్రొఫైల్ అయిందా, ఫిల్ అవుతుందా? No, you are not pushing the table. Actually, I am looking at that. This radio fake portion.
Weather fill in.
కాదు నీకు అర్థం కాల. Unless that well cell fills, I cannot stand. That's what I am telling you. మనం ఒక 2 millimeter dilatation ఇద్దాం, 2 millimeter balloon తోటి. Just will give tack up dilatation. Otherwise, we cannot stand that. 2 millimeter balloon is just. Otherwise, we have to end up with some drug-coated balloon, something. ఫస్ట్ డైలేట్ చేయాలి సార్. కింద లేదు, కింద డిసెక్షన్ రాదు. 2 millimeter 4 atmospheres సార్. డోంట్ గో మోర్ దాన్ దట్. క్రేనియల్ కి రా బాబు. Because distally it is not filling retrograde. That's why I got it out. Only 4 atmospheres. Bas. Okay. Now 2.5 we give Wolverine. బెటర్ ఇప్పుడు. బెటర్. సమ్ బ్రాంచెస్ ఫిల్లింగ్. యాక్చువల్లీ డిస్ట్రక్షన్ ఏం లేదు. దేర్ నో డిస్ట్రక్షన్. బ్లాక్ ఎక్స్పాండ్ కాలేదు అంతే. డిస్ట్రక్షన్ ఏం లేదు యాక్చువల్లీ. 2.5 అలోర్ ఇవ్వండి. Maybe if the distal vessel is not good, just I do a drug-coated balloon above and come. Dissection ఏం లేదు. ఉందా?
Previous
నాకు
injection,
తెలియదు ఏమంటే.
before dilatation one injection. This injection.
అది ఫేజిక్ మీరు ఫేజిక్ గా పెట్టడం వల్ల మీకు అలా అనిపిస్తుంది. ఫీల్ చేస్తే లేదు అక్కడ ఏమి. అదా కింద. ఓకే సరే కవర్ చేద్దాం.
ఇటు పక్క.
అక్కడేనా? ఈ 2.5 ఇవ్వండి.
మొత్తం 10 ఇచ్చాను.
2.5 ఇవ్వండి బాడీ. అదే కదా చేయండి.
అరే 2.5 ఇంకోటి
బాడీ వెయిట్ ఎక్కువ కదా ఇవ్వండి. నామినల్ ఎంత?
6, 5, 6. That's it.
8.
7, 8, sir.
తీసే. ఇక్కడ చేస్తారా? అక్కడ చేయండి. 6కి వెళ్ళండి.
3, 4, 5, 6.
చాలు. అక్కడ చేయండి.
3, 4,
6, 8, 9, 10, 10,
total
10,
2005.
11, 12.
12, sir.
Cutting.
Do it here.
Four, 5, 6, 7, 8,
9, 10, 12, 14. 14. ఇంకా చేయండి.
4, 5, 6, 7,
14కి వెళ్ళండి.
10, 11, 12, 13,
14. ఓకే. ఇది ఒబీస్ వలన రేడియేషన్ వస్తుంది. మీకు అర్థమైందా? నాట్ బికాస్ ఆఫ్ అవర్ యూసేజ్. చాలు. ఓకే. ఇంజెక్షన్ ఇవ్వండి సార్. కొంచెం ఆర్ఓ క్లినిక్ తీసుకుని ఒక ఇంజెక్షన్ ఇవ్వండి.
ఓకేనా? ఆ? అదే
ఎంగేజ్ అయిందా?
స్మాల్ టెస్ట్ ఏమో, స్మాల్ టెస్ట్, స్మాల్ టెస్ట్, స్మాల్ టెస్ట్. ఓకే
ఇయ్యండి. బానే ఇట్స్ ఓకే. Diffuse disease vessel, but above we have to stent it. ఒక షార్ట్ స్టెంట్ పెడదాం ఇక్కడ. We don't go for in between. It looks good only. There is nothing. So 2 short stents will put in this 2.5 ఇవ్వండి. 2.5 synergy ఒకటి ఇక్కడ నుంచి ఇవ్వండి. ఏది బాబు, నువ్వు వెళ్ళకు, నువ్వు అసలు ఇక్కడి నుంచి కదలొద్దు. డోంట్ గో దేర్. యూ వాంట్ అనదర్ బాయ్, ఐ విల్ అపాయింట్. షో ఫ్రమ్ వేర్ టు వేర్ చూపించాలి. ఒక నిమిషం. కనపడట్లేదు. అక్కడి నుంచి అక్కడి వరకు 2.5 అంటే 22 సరిపోతుందా? 24 తీసుకో. దీన్ని అబౌవ్ కాడల్ వ్యూలో ఇచ్చావు కదా, ఎంత ఉంది అది? 3 తీసుకుందాం. కాడల్లో ఈ షాట్ లో చూడు, అక్కడి నుంచి తీసుకోవాలి నువ్వు. అది ఆ బల్జి నుంచి చాలు కదా. అక్కడి నుంచి మేబీ 16 షుడ్ బి ఓకే. ఇన్ బిట్వీన్ సెగ్మెంట్ విల్ లీవ్ ఇట్.
Sir, good morning. This is Dr. Kantilal here from the auditorium. Are you able to hear me, sir? Hello?
గట్టిగా 22 అన్నాడు అంతే. 24 20?
Dr. Sudhakar, Dr. Suryaprakash, sir.
20 సరిపోతుందంటావా?
ముందుకు రావాలా, ఎందుకంటే అక్కడ ఒక లీజన్ ఉంది.
అది క్రేనీలోనే చూపించు. ఒక నిమిషం సిస్టర్. 24 కావాల్సి వస్తుంది. 24 తీసుకోండి సిస్టర్. 24 తీసుకో.
హలో హలో
Sir, are you able to hear me, sir? Hello?
అంతే కదా, చాలు అంతే కదా.
హలో
కాంటెస్ట్ ఎందుకు ఎక్కువ ఇచ్చాడు? అంతే కదా మనం అనుకుంది.
హలో
చేసే డిసెక్షన్ కవర్ చేసాం కదా.
హలో సురేష్ అన్న, డాక్టర్ కి మన వాయిస్ వినిపిస్తుందా?
చెయ్యి, నువ్వు చెయ్యి పర్లే.
2, 4, 6, 8, 10, 11 nominal, sir.
చాలు. వేరే బెలూన్స్ చేద్దాం. కాడలకి రా, అక్కడ లెంగ్త్ ఎంతో కూడా చూద్దాం. వేరే బెలూన్తో చేద్దాం. గైడింగ్ పట్టుకో. చిన్నది అక్కడ పెట్టాను. ఆయనకి అంత అక్కర్లేదు యాక్చువల్గా. ఇది 24 కదా, 16 సరిపోతుంది. చేద్దాం సార్, ఇది చేసేసి ఈ స్టెంట్ కూడా చేసి చేద్దాం. అంతే. ఇది చూపించు బస్సు, దీన్ని బట్టి డిసైడ్ చేద్దాం. లాంగ్ ఇప్పుడు మనము వీఆర్ నాట్ గోయింగ్ టు ఇక్కడి నుంచే ఆ మిడిల్ అవుతూ ఇచ్చేసే అయితే నో ప్రాబ్లం. ఐ వాంట్ టు అవాయిడ్ లాంగ్ స్టెంట్స్. 38 ఇది ఎంత 24 కదా, 32 తీసుకోండి అయితే.
Sir, are you able to hear me?
32 తీసుకోండి. ఈ షుడ్ నాట్ గో. ఉందా 32? ఇవ్వండి, ఆలోచిస్తున్నారంటే. ఏంటి ఆలోచిస్తున్నాడు?
హలో,
తీసుకోండి.
హలో.
Single screen, you mean, right? The fluoro.
लाइव का बड़ा होना
Now it is.
ఇచ్చాం
చాలు, ఇంకా చాలండి.
టోటల్ 12,500 ఇక 1 hour ఎగ్జాక్ట్ 1 hour.
ఇదే వెలుగుతో
Hello.
కింద
Hello.
చేద్దాం, నేను దాంట్లో దించాను.
Auditorium.
ఒక 3 తీసుకుని కింద పైన చేద్దాం.
Hello. Shiva, cameraman Shiva.
Who is the camera?
శివ లేదండి సార్ మాట్లాడతారు ఒకసారి.
Shiva.
హలో, హలో, హలో.
హలో,
ఎస్ సార్, ఎస్.
మన ఆడిటోరియం నుంచి మాట్లాడుతున్నాం.
బాగానే ఉంది. మరి చేయి.
Dr. Surya Prakash, sir. Sir, are you able to hear, sir?
అంతేగా, ఉంది క్రినిల్ క్రిన్ ఓవర్లాప్ ఉంది ఓవర్లాప్.
ఇప్పుడు ఓకే. వెళ్ళేవో కాడలు అరేవో.
Check 1, 2.
మళ్ళీ ప్రోక్సిమల్ ఎండ్ లో వదిలేయాలి. ఓవర్లాప్ ఉందా?
ఓవర్లాప్ మన కాడలు తీసుకున్నాం సార్.
బాడలు కొంచెం మిస్ అవుతున్నాం అనిపించింది కొద్దిగా. ఉంచండి, ఇంకో కేసుకు ఉపయోగపడుతుంది. ఉండదా? వీకెండ్ అన్నట్టు కదా. అలా ఉండని. ఇచ్చేటప్పుడు మీరు ఐవాస్ కదా ఉంది కదా, చెప్పాలి కరెక్ట్ గా లెంగ్త్.
ప్లాన్ మారింది, ప్లాన్ చేంజ్.
యాక్చువల్గా డిసెక్షన్ ఏదో ఉందన్నారు అక్కడ, లేకపోతే నేను పెట్టేవాడిని కాదు. I did not see that. I want to avoid long stint actually. లాంగ్ స్టెంట్స్ వద్దనుకున్నా నేను. ఉందంటారా? అది కవర్ చేశాం.
జస్ట్ సెప్టల్ ముందర
సెక్షన్ వి కవర్డ్.
సెప్టల్ ముందర
30 million తో వస్తాయి dissections. Angioscalp తో రావు usual గా what I observe. Next case angioscalp ఇయ్యండి. We can remove the right catheter. Why unnecessary? ఒక్క నిమిషం ఉంచండి. Okay, fine. This is also important. Once the job is over, better remove the donor artery. Huh? ఇప్పుడు ఓకే టీం నుంచి కవర్ చేయాల్సి వస్తుంది అంతేగా
బట్ కొంచెం
కొంచెం వెళ్దాను
కొంచెం వెళ్దాం ఏజెంట్ కోసం
అంతే. హలో కాడలి సరిపోతుంది. చేసేయండి సిస్టర్.
ఓకే
అయిపోయింది.
6, 8, 10, 11 nominal, sir.
Cranial. Now take a 3 balloon, sister. How much it can go, this balloon? Maybe you can tell about that balloon. You can go that side and
what is the nature of the bill?
open అయిందండి.
Raspberry Apollo bill. Semi complaint on NC bill. Okay, 3 to below. Okay.
We are doing 3 we are doing. Okay, we will go to 10. We'll see 2.5 the 2.5 balloon తీసుకో. That you can go. Nageshwarav patient you can shift. నువ్వు వెళ్ళకు దానికి వెళ్ళే ముందు ఒకసారి ఏసీటీ విల్ చెక్. So for anti-grade techniques we keep 300 like that. ఇక్కడ చేసిస్తే 14. డిప్లీట్ చేసారా? ఓకే. Balloons. I will go down.
Lower left.
This balloon profile is gone. వెళ్ళవండి ఈ అపోలో ఇవన్నీ
12,
14.
14.
These balloons won't go on. One more Apollo if you want to give, give. Babu, one more N Apollo you want to give. But this one, no? This one don't take. You give that one, that will finish. వెళ్ళు సరే. నేను ఎప్పుడు ఇచ్చేయలేదు. How much is the pressure? Burst pressure? Previously, I never used this one. I never used. చాలు చెయ్యి.
8, 10,
12,
12,
14,
14, sir.
16.
16.
చాలు. Go here 8.
6, 8, 10, 12, 14, 16, 18.
18.
10, 12, 14, 16, 18.
Do it here.
6, 8, 10, 12,
16,
14,
18.
16, 18.
తీసుకుని చెయ్యండి పర్లేదు.
6, 8, 10, 12, 14, 16, 18. Ten, 12, 14, 16, 18.
తీసే చేద్దాం. త్రీ తీసుకు.
Right.
Take the IPS again after 3. This is because of his obesity that release. But we put a rat bed. It observes at least 50% radiation. How much rat pad can absorb radiation, Santosh ji? No, that new egg nest system, that they say 90% claim. Rat part not that much. They say 50% scattered radiation. Because once the obese patient, radiation dose is high. Because I rarely use it as CINES, if you observe. We are doing most of the fluorosaves. We are using less contrast. But even then, that when then the cranial view, what you are using the cranial view, you have to avoid the cranial views in CTO PCA, but that's the most useful view for a lady, unfortunately. ఇంకెళ్ళింది చాలు
10, 12,
18 కి వెళ్ళింది.
8,
18.
10, 12, 14, 16, 18.
18.
12, 14, 16, 18.
Come to caudal. Correct? Correct? Correct, na? Correct. You do it.
Ten, 12,
14, 16, 18, 20. We'll do IVAS. We'll do IVAS, no problem. IVAS చేయండి దెన్ ఎన్టీజీ ఇచ్చి అయిపోయింది.
Then please tell the whole summary of that.
I'll tell once IVAS is over.
ఇంకొంచెం ముందుకు రండి.
Little
సార్
exception.
సరిపోతుంది కదా? ఓకే, నేనేం బట్టి
IVAS recording after the stenting with high pressure dilatation. no edge dissection, and the distal stent looks apposition acceptable. There's an overlap of the stents of the 2.5 and 3. That looks okay. The 3 stent. Previous one. The stent looks expansion is okay. At the ostium, at the circumflex also, no struts into the circumflex. Left main appears clean, no struts in the left main. And just tell the area achieved by the IVAS mean stent area, how much?
Hmm. Hmm. Yes. Hmm.
We can go to 24 atmospheres at the same balloon. You can give same balloon. You can.
Hmm.
Maybe at the proximal end, we'll go with a 3.5 balloon. Three neighbor. Three neighbor. Overall, it's okay. Balloon bridges.
Hmm.
Maybe. Which balloon? What is the bookmark of that? This area, where in the lower stent? Ravi?
Ravi garu?
This area is in the lower stent? Just use with the same balloon, I'll go to 10 atmosphere. Will just
4.5 is accepted.
we'll do it at 3, no problem.
Yes, yes.
We'll expand that.
Round.
This is the usage of imaging where the follow-up looks good after a good opposition and there's no malopposition, that we have to spend time in these cases.
That is overlap. Okay.
The two steps and proximity to the overlap.
Exactly. You do it here. That's the overlap actually. And do it there.
10,
12, 14,
14,
16.
16.
Yes. This. Do it here.
10,
20, 22, 24. 20, 22, 24.
24.
Okay. Expand here.
6, 8, 10,
22,
20,
22. Do it here. You go to 24.
20, 22, 24.
You can see a send boost here. Then we'll come out.
Okay, Baba. ఓకే ఓకే ఇక్కడ బెండ్ దగ్గర ఓకేనా you can go little bit, 24 still
Huh?
Uh,
Yeah,
this is 3
this is 3.
this is 3 we can go 24 go ahead.
Yeah, we can go to 24. No problem. We just do it 24. Resist ikkada. 24 you go.
18, 20, 22,
24, 26.
అంతే అది good.
I think so.
Accept.
back.
Okay, okay, you do it there. 24 you go.
16, 20, 22, 24.
26.
20.
Bas. Enough, I think. Take some Nikron something. NTC and Nikron you take.
ఏమ్మా yes, okay. ఇదేందమ్మా ఎట్లా పైకి పట్టుకో
Come to cranial. Baba. Nikron also. We give nitroglycerin and Nicrondyl as
ఇదమ్మా
because chronic distal embolization with high pressure dilatations of the chronic debris and some distal vessels vasodilation.
Equivalence.
These things happen. That's why routinely we give. How the distal vessel grows over 6 months period, we have to watch these patients. And that is deceased. I think we have done the job here. You take good contrast, give one cranial and one caudal. Good injection. Ask him to focus properly.
బావు డిజిటల్ ఓకేనా ఓకే బాగుంది
Distally deceased vessel. You take a caudal view also.
ఓకేనా
You take one lateral view. Usually you see the distal vessel nicely
రెడ్ లెటర్
in the lateral view. Even though it produces little more radiation. Focus that white one. Put the leaves. No, wait. Please wait. We use distal LED. We want to see.
ఓకేనా బాబా కింద అది
Put the no, let him put everything, sir. Leaves and all.
పెట్టాడు ఓకే
Okay. Come. Because the white thing you cannot not. This is AP, yeah? This view, last view. This view area. And this same thing AP. తీసుకోండి సార్ మంచిగా తీసుకుని అయిపోయింది.
ఇస్తానండి అయిపోతుంది. ఓకేనా బాబు కింద
అంటే ఇవన్నీ ఇస్తారా? బాగానే ఉంది సార్, ఇట్స్ ఓకే.
ఏమైంది
తీసేసాక అయిపోయింది. ఇది ఇన్ఫెక్షన్ ఇవ్వండి సార్. ఏంటి ప్లస్ వాటర్ తీయమ్మా ఆయనకి.
కొద్దిగా చిన్న గ్లాస్ లో కొద్ది వాటర్, చిన్న కప్ లో పేషెంట్.
కనెక్ట్ చేయండి, ప్రెషర్ కనెక్ట్ చేస్తే వేసవిగలు వస్తాయి. ప్రెషర్ కనెక్ట్ చేయండి, ఎప్పుడు తీకండి తొందరపడి. కొంచెం ఫ్లూయిడ్ అది ఇవన్నీ వేసవిగలు వస్తాయి.
ఇచ్చాం కదా
అయినా అప్పుడే తీకండి, అయినా వేసవిగలు వస్తాయి. ప్రెషర్ కనెక్ట్ చేయండి,
ఏంటి ఇచ్చాం.
ప్రెషర్ కనెక్ట్ చేయండి.
చూడు బాబు
కొంచెం ఫ్లూయిడ్ ఇవ్వమ్మా.
అది పంపించాను, కొద్దిగా ప్రెస్ చేయండి. అది
అయిపోయింది ప్రొసీజర్, కొద్ది కొద్దిగా తాగు.
చేద్దాం.
లిటిల్ ప్రెషర్ ఇంప్రూవ్. అయిపోయింది ప్రొసీజర్ సక్సెస్ఫుల్ గా. తగ్గుతుంది. ఫ్లూయిడ్ ఇవ్వండి కదా
బాబు, ఫ్లష్
ఒకసారి పెరికార్డియం చూడరా.
బాగానే ఉంది సార్.
అంటే వేసవి వచ్చింది ఆయనకి, నేను అబ్జర్వ్ చేశాను.
ఏం కాదన్నా, తగ్గుతుంది.
షుగర్ చూడండి ఒకసారి.
124 బీపీ 124.
నాలుగు చూపించు ఒకసారి. అంతా బాగానే ఉంది.
ఓకే, కంగారు పడకండి, మంచిగా ఉంది.
ప్రొసీజర్ అయిపోయింది.
ఏమా ఎందుకమ్మా, బాగానే ఉంది.
ఏంటిది
హార్ట్ రేట్ బాగానే ఉంది.
ఎట్రిపెన్ ఇవ్వండి, పర్లే. వేసవిగలు వచ్చింది ఆయనకి, అంతకంటే ఏం లేదు.
బాగానే ఉంది, జస్ట్ హాఫ్ మళ్ళీ పెరుగుతుంది.
ఎట్రిపెన్ ఇచ్చి ఫ్లూయిడ్ ఇవ్వండి, వేసవిగలు అంతకంటే. దగ్గండి 2-3 సార్లు. దగ్గండి. వెరీ గుడ్. అంతా అయిపోయిన తర్వాత ఇప్పుడు టెన్షన్ ఏంటే బాబు? పొద్దునుంచి ఏం తినలేదు కదా, అందుకని అలా అనిపించింది. 4 చూపించండి. ఫ్లూయిడ్ ఇస్తున్నారండి, ఫ్లూయిడ్ ఓపెన్ చేయండి. వినశీతిలోకి ఇవ్వచ్చు, అక్కడ వినశీతి ఉంది. ఒకసారి ఎక్కువ చెక్ చేయండి. బాగుంది సార్, నో ఎఫ్యూజన్. బాగుంది, హార్ట్ అంతా బ్యూటిఫుల్ ఉంది. ఈయన చాలా యాంగ్జైటీ పర్సనాలిటీ సార్. బేసిక్ గా హెమటమైన్ లేదు చూడండి, ఇది చూడాలన్నమాట మనం. హెమటమైన్ లేదు అటు. కొంచెం ఫ్లూయిడ్ ఇవ్వండి, ఇచ్చిన తర్వాత తీసేద్దాం అది. ఇందాకటి మీరు తగ్గలా ఈ ట్యూబులు కూడా తీసేస్తాం ఇప్పుడు. విల్ రిమూవ్ ద ట్యూబ్. కాంట్రాస్ట్ ఇవ్వండి సార్, రెండు పక్కల ఇచ్చి చూడండి. ఒక పక్క యాంజియోసీలియస్, ఒక పక్క మాన్యువల్ తీద్దాం.
రెడీ ఉంది సార్.
ఓకే. వచ్చింది చూడండి, వచ్చింది 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 వచ్చిందమ్మా.
వచ్చింది సార్.
కట్ చేయి. ఇది ఎలా కట్ చేస్తా? ఇది కట్ చేసి
వచ్చేసేపు హోల్డ్ చేసి
Hmm.
చేద్దాం సార్.
మరి చేస్తూ ఉన్నాడు ఈయన.
అయిపోతుందండి.
క్లోజ్ చేశానండి, లేకపోతే 3 గంటలు పట్టుకోవాలి ఇది. ఆ.
These are medical that's
So maybe you have to use a IVL or rota, but it's కవర్ కవర్ చేయండి, మంచి కవర్ చేయండి. కవర్ మంచిగా చేయండి, లైవ్ కదా. అడుగు కందిలని మాట్లాడచ్చు. సో దే Ravi, 1 minute, Ravi, 1 minute. You focus on the IVS when I ask you to focus. So, dear colleagues and people who are watching this academy cases, mainly targeted the fellows and who are learning the CTO PCA, and also getting some inputs from the seniors who are already doing this CTO PCI. So it's a opportunity for me and for you also to share the views. This first case is a young gentleman. As you know, Indian hearts are crying at every young age. He is very young, 32, and as risk factors being morbid obesity, more than 100 kgs weight, and the family history. And he went with acute coronary syndrome to another hospital with a circumflex occlusion, which has been opened, put a long stent was done, that, and the LAD found to be a CTO. The retrograde vessels, collaterals are not that happy. If you see, there's a PDA disease, RCA is okay, but the exit entry points of the collaterals were distal, and the distal LAD also appears diseased. So ideally, the option, because the LAD is LAD and his LV function is well preserved, that's important. That's why it must be a viable myocardium. And I've seen many people, particularly in LAD territory, people get benefit. So we took him because the distal LAD is not that diseased and grafts may not accept. It's a long segment disease. So we took up the challenge of doing a CTO PCA in this extreme morbid obesity. Mainly the access problems will be there. But as you know, we have put a 5 French sheath on the other side and given an injection for the main vessel 7 French sheath to puncture just above the bifurcation for usage of the vascular access device in this obese patient particularly. And I do avoid radial procedures in this patient because of the very small and it will be cumbersome, more radiation. So femoral, bifemoral approach 7 French or 8 French is my standard in CTO PCI, even though it is a dedicated radial center. So EB has been taken as the guiding catheter 7 French on the left system, and a diagnostic GR is taken on the right side. We have taken 2 views in the donor artery for sedule injection, which, as I already said, gives you the length of the lesion, the calcium, the tortuosity, the collaterals, the caps, proximal cap, distal cap. So they are putting together, it's a long segment CTO with calcium, maybe the CTO score is 2. The main important thing here is you should have a microcatheter with a wire. First you try internal tracking. That's what a polymer jacket wire is a choice in this as an initial first wire. But yes, there is some buckling. But before taking the polymer jacket wire to the cap, I always prefer a routine wire like a Cyan Blue or a BMW to the proximal cap, because not to disturb the character of the CTO wire tip. That's very important. So this Carvel 135 has taken to the distal cap. Then we checked in 2 different views in the retrograde injections. Mostly I use the fluoro. Unfortunately, this machine giving with extreme obesity radiation, but I use fluoro systems, fluoro save. That's a very, very important once you become a regular dedicated CTO operator, and don't go to the cranial views. But unfortunately, in this LED, I have to use the cranial views. So these points are very important whenever you, and I use a rat for the system for the scattered radiation can be cut short. We have seen in many cases with the dosimeter documented. So the filter XT wire, which is buckling at the site of the CTO with the calcium. So I went to a caudal view again and checked whether my position is correct or not. You see, that's very important. You see the caudal view. Then I pull my microcatheter back when it is not in the true lumen here, then redirected the wire. Yes, a polymer jacket wire is not the correct wire to redirect, unlike Gaia, but a little tip modification you can do that. Then I came back to the cranial view again. And here I can, on the cine, I can cross the lesion with the field XT wire. And the corval catheter navigation over this wire is not possible because of the calcium and the tight lesion. So we don't try hard in these lesions because the entire system may come out. So better you take a balloon trap technique and take out the carval and do a balloon dilatation. Here I used the alveo CTO balloon, which crossed it nicely and dilated the lesion. And then we used, because once we do IVAS, Ravi, who is expert in the Boston IVAS, has shown the distal vessel is around 2.2 millimeter. And the site of CTO, there is a calcium, and proximal to that also there is almost 260 degrees calcium, but it is an internal calcium, not in depth calcium. And the proximal where I thought of fibrotic lesion also had a lot of calcium size becoming around 3.25. So with this strategy, we have again adopted a debulking modification, block modification strategy. We use it here Wolverine balloon 2.5 for the middle one and 3 for the proximal. And we dilate up to 14 atmospheres. I have seen Anthony Colombo going up to 20. Wolverine we can go, but unfortunately that pursues a dissection in the mid portion. My idea is to do a spark stenting or doing a DEB in this case because of the distal disease, but there is a dissection after the Wolverine balloon, so I have to go for stenting. So we try to put a spot stent in the mid portion of the dissection portion, and 2.5 synergy has been deployed of 22 synergy required at 11 atmospheres. Then the proximal one we try to cover, but there's small flap before the distal stent. That's why we covered from ostium to the with the overlap stenting of a 3 synergy stent with a 38 that covered the ostial LAD to this thing. So usually you see remodeling in these vessels. We have given some antigen, corundel, and dilated a 3 stent, and then we given high pressure dilatations. Here we used Acuforce balloon. In this, we tried Apollo balloon for the 2.5 stent, but we need to go to very high pressure. We use the Acuforce with the 28, 26 atmospheres, high pressure dilatation of the overlap area and the proximal stent ostial. IVANS has shown that ostium has to be related to 3.5, so we again went ahead with the 3.5 NC balloon we stretched. Finally, we had a decent result considering the badly diseased vessel. If you can see the cranial view, next view, next view, next view, next. We removed the wire, and this is a final result, a diseased LED as expected. But I think we have seen many times over 6 months time the distal LED likely to grow, and we'll do check angio or a CT on the follow-up. The axis has been closed with the angioceal on the right one. So usually we do because of the to avoid the vascular problems. Also, the contrast used is around 180 ml contrast and 5 gray radiation, but it's not expected to be that high because of his obesity. Because most of the times we have done a fluoro save, even the wire cross balloon save thing. This is the case, anti-grade wire technique with IVAS guided CTO PCA in a young male. Hopefully, he should improve over a period. Thank you all for witnessing this case. Any queries, anything you can put in the chat. I'll be happy to answer it. Thank you all. You can shift.
going to disconnect the camera. Then we come back to the auditorium. Step by step बोलना पड़ता है.